Hi, I'm Lisa Malter from NYU Grossman School of Medicine, and I'm going to speak to you about healthcare maintenance and preventative care in our patients with IBD. And I'd like to take a moment to just kind of shout out that it is absolutely fantastic when our patients have primary care providers, but because most of our patients get diagnosed between ages 15 and 30, and they're not used to kind of really being in the healthcare system, oftentimes we as gastroenterologists end up kind of serving as their primary care providers. But when I get to partner with a primary care provider, it makes my job so much easier. And a really common question that I get from primary care providers is about vaccines. I think that there's obviously some appropriate concern about our patients that are on immunosuppressive therapy, and it's reasonable to ask questions to make sure we're optimizing our preventative health strategies for our patients. So one question I get is typically about live vaccines. And with our immunosuppressive medications, our biologics, and our small molecules, we definitely don't want to administer live vaccines during therapy. If we have the luxury of a window prior to starting therapy, we will want to give our patients any of the live vaccines. This would be things like measles, mumps, rubella, varicella vaccines at least 4 weeks before starting treatment. If we don't have the luxury, sometimes we just are aware that our patients may not be immunized to some of these diseases, and we just have to act accordingly. In terms of other vaccines that are indicated, I'd like to take a moment to highlight some really recent changes for our patients with regard to vaccines. So pneumonia vaccines are recommended for all of our patients that are immunosuppressed, and there has been a recent change as of February 2022 by the ACP, and I would just encourage everybody to take a look at the CDC guidelines for recommendations regarding the pneumonia vaccines, and this includes the use of the Prevnar 15 and Prevnar 20, which is a little bit of a shift from the Pneumovax 23 valent and the Prevnar 13. So it's a little bit cumbersome to cover today, but just to highlight and create some awareness around that changing recommendation. The next vaccine recommendation that I'd like to highlight that's undergone some relatively recent changes is that for zoster. So there are specific medications, in particular the JAK inhibitors and the small molecules, including S1P receptor modulators, that would benefit from getting a zoster vaccine. Maybe before, but definitely at the initiation of therapy. But there's actually a new recommendation as of last summer on the zoster vaccine that patients should be getting this if they're over 18 and immunosuppressed. So this includes any of our patients on biologics over 18 should be getting our non-live recombinant Shingrix vaccine. The last kind of new update that I'd like to cover is that of the HPV vaccine. So this is indicated for men and women ages 9 to 26, but there has been an expansion to include patients 27 through 45 when they may be at risk. So this is an individualized conversation, and this is really for patients depending on their social behaviors and not being in monogamous relationships. You do want to consider that vaccine. We always also want to just make sure our patients are getting an annual flu shot. If they're on a biologic or a small molecule, you want to make sure that's not a live, so an injectable type of vaccine. We want to make sure our patients are up to date with their tetanus immunizations, hepatitis A, hepatitis B. So the next question I'd like to move to is that about COVID vaccines, and this comes up quite frequently with our primary care providers. And I think that there's a few just kind of bullet points that I'd like to cover with you in terms of if there's any questions about the vaccine, the efficacy, et cetera. So number one, COVID vaccines are recommended for all of our patients, no matter what medication they're on, no matter if they're sick, if they're not sick, get them the vaccine. And there does not seem to be any research that has demonstrated any risk of flare when getting the vaccines or boosters. So it's really just get them vaccinated when you have the opportunity to get them vaccinated. There has been also the question about efficacy of the COVID vaccines in our patient population, in particular in those patients that are on immunosuppressive medications, and some recent research that has come out that has really demonstrated great efficacy of these vaccines with our IBD patients, which is really promising. And so we are just really encouraging patients to get vaccinated and to be able to share with them that this vaccine is going to help you really quite similarly to all comers who are getting the vaccine. The last question I want to cover this morning is that of kind of other categories of healthcare maintenance that are important to be considering when co-managing a patient with inflammatory bowel disease. So we want to take into account bone health. This comes up with patients that are malnourished and may be suffering some nutritional deficiencies, and so we want to be paying particular attention to those patients. We also want to pay attention to bone health in patients that have had particularly long courses of steroids or multiple courses of steroids during their course of inflammatory bowel disease. So this can be individualized based on the patient. For all patients, we like to be paying attention to their vitamin D level, though, regardless of treatment or nutritional status, because it does play a role in inflammation, and we want to make sure that their vitamin D level is optimized. Another category is that of cancer prevention. We as gastroenterologists take care of the colon cancer, so you don't typically have to worry about that as a primary care clinician. However, there is a role for evaluating for cervical cancer in our patients that are biologically female if they have been on immunosuppressive agents. The recommendations for evaluating these patients with a pap smear on an annual basis is in place, in contrast to patients that are not on immunosuppressives that can wait longer windows in accordance with the recommendations of the American College of Obstetrics and Gynecology. We also pay attention to skin cancer. Really, just to keep it simple, our patients that are on any immunosuppressive medications or really have had a history of immunosuppressive medications should be seen by a dermatologist on an annual basis just for a total body skin exam. And we recommend things like sun protective clothing and sunscreen when they're out in the sun. We also want to make sure our patients aren't smoking and giving counseling and potentially pharmacologic support to address smoking cessation is critical. And then lastly, we like to pay attention to other aspects of functional ability with IBD, paying attention to anxiety and depression, because there is a appreciation for the fact that these conditions can be quite prevalent in our patients with inflammatory bowel disease and can impact their motivation to participate in care and their outcomes. And so being able to assess for these things and get patients into the appropriate supports or treatments that they need to get them optimized from a mental health perspective is really essential to optimizing their overall care as a patient with inflammatory bowel disease.